This is a senior rehab podcast, the podcast for rehab clinicians that want to better serve older adults.
Hi, everybody. Welcome to Senior Rehab Podcast. I'm Erinn Carey.
And I'm Tali Spaceman.
You're listening to the Senior Rehab Podcast Shorts. So welcome to our series on frailty. This is the first episode, or the first Shorts episode of the series on frailty, where we're going to be talking about the basic definition of frailty and the history of the term and how it's become the popular topic it is today. Do you have any questions about frailty before we get started?
Not questions. I'm very excited to make some things clearer.
Okay, so most simply, frailty is defined as a syndrome of physiological decline in late life. And what we see with this sort of decline is that this population has an increased vulnerability to adverse health outcomes, such as complications with procedures like surgery, having more falls, being institutionalized, experiencing disability, or death. And it's considered the, quote, hallmark geriatric syndrome because it comes before other geriatric syndromes such as falls, fractures, delirium, and incontinence. I just wanted to clarify before we get started that just because someone is older does not mean that they will automatically be frail. Many older adults remain vigorous throughout their late life, as I'm sure many of our listeners know already. What I want to do is I just want to go through a history on frailty in the literature today in this episode. When did the greater discussion in healthcare about frailty begin? Geriatricians have actually been around in the USA since the early 1900s, and although this has been the case, it wasn't until 1990 when the American Medical Association White Paper on Elderly Health Report of the Council of Scientific Affairs was published. And what this was that the AMA got together and they were looking at the growing population of older adults in the United States and how that population was pretty much exploding. In 1900, there were about 3 million people over the age of 65. In 1984, that had tripled to 12 million. And their estimate was that by 2020, there would be 64 million. So this, because in general, older adults tend to use more healthcare resources. This is what they were bringing to the attention of the greater healthcare community, talking about the need for more specialized education and research in the older adult population. For reference, in the 2014 census, there were 46.2 million adults over the age of 65 in the United States. So the growth has slowed a little bit, but it's still on track to be close to that 64 million estimate by 2020. So the American Medical Association came up with 4 recommendations that they published in this paper. 1 is to incorporate geriatric medicine into medical school curricula. 2 is to urge specialties to emphasize further education and research on the problems of aging and healthcare of the aged. 3, they encouraged all appropriate medical specialty certifying boards to assess pertinent knowledge regarding care of the aged in their certification and recertification process. And 4, they endorsed the concept of affiliation between nursing home facilities for geriatric patients and resident training programs.
And that was in the 1990s.
That was in 1990 was when this paper was published.
That's wonderful. I feel that we would catch it later as a society because we would notice it when people need to be replaced in the workforce. But as a medical field, I'm glad almost 30 years ago people caught it because it could have been a disaster if we haven't noticed the whole population. I feel that we still don't really see them.
Yeah, especially in the United States because unfortunately because we're so focused on independence, what tends to happen with our older adults is that, once they stop producing things for the economy, we put them in a home and focus on the younger people who can actually produce things for us. But yeah, so we tend to notice the things that we interact with most in the population. And because in the United States, you don't really interact with older adults unless you live in an urban environment where there are lots of community-dwelling older adults, or you work with them like in healthcare. It makes sense that the healthcare field, or like people working in healthcare, noticed this and brought this to the attention of the larger population.
The action they took are really good. It's because there's one thing noticing a problem and one thing actually taking steps in order to confront that problem.
Yeah, and even though these are like just suggestions, they're concrete suggestions that are pretty easy to implement, I would think.
Yeah, imagine that they didn't study geriatric in med school. Imagine how horrifying that would be. It would be like, you know what, you're over 65, I don't know how to treat you.
Yeah, just, do your thing. Here's some blood pressure medication.
God, that's like horrifying.
Yeah, the fact that they were like, please do this. Please please incorporate this medicine into the curricula, and that it wasn't already there is kind of striking.
Yeah.
So it seems like this paper was instrumental in facilitating the broader conversation on how to provide care to older adults, like we were just discussing, and to popularize research into geriatric syndromes such as frailty. So with that in mind, how do we define frailty? There are a lot of definitions.
There's a lot of definitions. Also, there's a lot of definition of different type of frailty. There's social frailty and emotional frailty and all kind of frailty.
I'm really glad you brought that up because as I was reading about frailty, it seems like a lot of the definitions are very physical ability focused. PTs tend to focus on the physical capabilities of our patients because that's kind of where we live. Like we do look a bit into the biopsychosocial domain, but it's hard when the screening tools we have to work with don't pay attention to that sort of thing. There are a lot of different measurement tools with differing conceptual bases that often fail to differentiate between disability, comorbidity, and frailty. So that's a quote from the up-to-date article on frailty. If you have institutional access, go check out this really awesome article from Up-to-Date. But they identified some conceptual commonalities between the different measuring tools. One is that they often examine multiple factors, like we were discussing, the medical, environmental, educational, psychological. So I feel like having this sort of more well-rounded way of assessing someone's frailty or assessing someone's function is more in line with the ICF model. So they take into account that all these different factors affect frailty, functional status, and physiologic reserve in older adults. They also point out that age, chronic comorbidities, and disability, while associated with frailty, do not establish the diagnosis of frailty. And frailty is on a spectrum, and at the far end is the failure to thrive diagnosis, which I hadn't realized but makes perfect sense.
Yeah, and I have to say, I work in a psych unit now, and I see it every now and then that a patient is being admitted because of a failure to thrive,
right?
Which you usually associate with peds and infants.
I actually don't.
Really?
I don't have a lot of peds experience, but like I think of older adults and failure to thrive.
Mm-hmm.
Yeah.
And somebody once put it in it's a morbid way, but it's a little bit of giving up, failure to thrive.
It is. Your kidneys are giving up. Your lungs are giving up.
Like your body and your soul are giving up.
Yeah, your body isn't able to adapt to the physiological stressors that are presented to it, which is frailty.
So that's the extreme case of frailty, failure to thrive.
Yeah, I'm glad that you also have thought about that and talked about that. Okay, so Christina Previtt has a PT on Ice episode about the 3 main ways clinicians in rehab and medicine define frailty. So she defined it as a vulnerability to external stressors, which is in line with what I read. And these patients tend to have a complex medical history. So the 3 popular ways to define it are the Fried physical phenotype, which was published in 2001. And this is what the PTs most often use. And we're going to talk about that in a little bit. The second is the Rockwood definition of frailty. It's more in line with use in the hospital setting, and it's more medical. And there are 2 scales within the Rockwood definition of frailty. The first one is the Frailty Index, and then there's the Clinical Frailty Scale. The Clinical Frailty Scale is newer and still getting validated. And then the third is the Tilburg Frailty Index. And this one also includes psychological and social domains rather than just the physical. Mm-hmm. So I breezed over those pretty quickly because I don't want to be redundant with another podcast out there, especially with someone who's like a friend to us. But anyway, I mean, I've never met her, but she and Dustin do the PT on Ice episodes. So I would recommend you listen to her podcast episode or the video on the PT on Ice Facebook page for an in-depth description of those different frailty definitions. Next, I'm going to talk about the screening tools for frailty. And I am going to talk a bit about the Fried scale just because it's pretty popular in PT literature. Fried's group wanted to establish a standardized definition for frailty, and so they took data from the cardiovascular health study, which had a population of 5,317 men and women, white and African American. They did a 7-year and 14-year follow-up, including annual exams and surveillance for disease, hospitalization, falls, disability, and mortality. So they came up with these 5 criteria where if 3 or more of these are present, then someone is said to be frail. The first one is unintentional weight loss of 10 pounds in the past year. Second is self-reported exhaustion. Third is weakness as measured by grip strength. Fourth is slow walking speed. And then 5th is low physical activity. Any comments on that before I go on to what they found?
Not everybody, but a lot of people, even though they're not frail, report that they're tired or exhausted. I have patients that still work, still very vital, and they're like, yeah, I'm exhausted. I wake up at 6 in the morning to go to the gym before work, and then I come back at 8, and then, I still spend some time with my wife. So yeah, I'm exhausted, but it's still very vital. So I wish this was a little bit more defined.
But yes, I agree. I think you're totally right about that. So what they found was that in this population of over 5,000 people, there was a 6.9 prevalence of frailty, and the 4-year incidence was 7.2%. And it was associated with being African American, having lower education and income, poor health, and higher rates of chronic disease and disability. So the frailty phenotype was predictive of 3-year incident falls, worsening mobility and ADL function, hospitalization, death, and honestly, this predictiveness has some pretty bonkers hazards ratios, up to 2.24 when adjusted for health, disease, and social characteristics. Before the adjustment, they were like 4 point something, and I was like, what? That's terrifying. So frailty it's terrifying.
It's terrifying, and it's a whole systematic thing. It's all over. It's everything. It's not musculoskeletal. It's not even just neurological.
Right.
It's part of the holistic view of us as people. Because humans are a social animal, society is also affecting us, our health.
I like that a lot. I hadn't thought about it that way, but you're absolutely right. Like, it's a holistic disease.
It's a holistic disease. Yeah, a very new age.
Super trendy. So then they also defined pre-frailty. Actually, what they called it was intermediate frailty status, which was if someone had one or two of those criteria present. So those people you were talking about who were exhausted, they would be pre-frail. Anyway, so this pre-frailty state demonstrated intermediate risk to the same adverse outcomes as the frail state, and it increased risk of becoming frail. And that odds ratio is 2.63. Again, bonkers. So then that was 2001. And then a 2006 study validated these criteria in the Women's Health and Aging Study population. So on to 2005, a group of researchers took the Women's Health Initiative Observational Study population, which was a population of 40,657 women.
That's a lot of women.
That's a lot of ladies.
All the single ladies.
All the single ladies.
Or married.
All the ladies.
All the ladies.
All the healthcare ladies. I don't know.
It's a lot of ladies, that's all.
Yep. The average follow-up for this population was 5.9 years, and they kind of did their own thing with the definition, where they took self-reported muscle weakness or impaired walking, coupled with exhaustion, low physical activity, and unintended weight loss, and called that as being frail. So they found that 16.3% of this population was frail at baseline. And what they did was they identified some risk factors associated with being frail. So a positive association, meaning that if this is present, they are more likely to be frail. Older age, chronic conditions, smoking, depressive symptom score, underweight, overweight, and obese. All make sense. So the next one, which I think is really strange, was the negative association, meaning that if these were high or present, it put them at lower risk of becoming frail. Income, no surprise. Moderate alcohol use.
Oh no.
Oh no.
Oh wait, moderate alcohol is like you are allowed to moderately drink it.
Also, living alone and self-reported health. If you live alone, you're less likely to be frail.
Because you need to do things for yourself.
Oh, that does make sense.
Okay, I can do that.
Yeah, let's
I hope I won't live
frailty.
alone for the rest of my life, but I can keep up with the alcohol.
So then on to 2007, where a group of researchers did the same sort of thing, but looked at men. So they came up with their own definition based on this population of older men, and it was sarcopenia, weakness, self-reported exhaustion, low activity level, and slow walking speed. So it's the same as the Fried criteria, except instead of unintentional weight loss, it's sarcopenia, which are honestly related if you think about it.
Notice that in women, moderately drinking alcohol and living alone is a good thing. And in men, I'm just observing, that's all.
I'm not judging, I'm just stating.
I'm not judging, I'm just stating. No, that's all I had to say.
All right, cool.
Just that, like, women take this glass of wine with the...
And you keep your apartment. So this also looked at demographics information on race and frailty in males. So this 2007 study was helpful in giving us a better picture of frailty with both males and females. So then in 2008, another group of researchers were looking at the Fried index, and they determined that the Fried index was a little little more difficult to use clinically. So they came up with a simpler index. So it took 3 components, which is just weight loss, general weight loss, not 10 pounds or more in the last year. The second is inability to rise from a chair 5 times without using arms. And then the third is reduced energy level, and they determined this as an answer of no to the question, do you feel full of energy on the geriatric depression scale? So a pretty quick assessment.
Not only pretty quick assessment, it's not only self-reported.
Right.
It's something that we can see.
So then in 2009, another group of researchers compared the Freed criteria plus the other one that we were just talking about. And again, they mirrored the previous assertion was that the Freed indicators are not clinically practical. So they validated using an independent elderly sample of diverse men and women. And what they found was that both indices were good at distinguishing geriatric conditions, predicting recurrent falls, overnight hospitalizations, and ED visits according to the level of frailty. But they did say that the simpler index may be easier and more practical in the clinical setting. So they're both pretty valid. They seem relatively reliable. So then, like I said, just traversing through the literature, in 2013, I found an article called Operationalization of Frailty Using 8 Commonly Used Scales and Comparison of Their Ability to Predict All-Cause Mortality. Why are there 8 scales that are commonly used?
I think maybe because it's still a little different in every state and country.
Okay, so then it doesn't get better. In 2016, a review talked about 67 frailty instruments.
Oh, they multiply
Yeah.
by 8. No.
That's a square. They squared.
That's what they squared.
They straight up squared. So this is where we are now. We have a ton of different instruments to use for frailty, some more popular than others, all with their flaws and strengths. So I really look forward to going through the information available on frailty with you in this series, Tali, because I feel like there's so much we could talk about, like 67 frailty indexes. Instruments.
I'm not gonna talk about 67 frailty instruments in a series because
it'd be a long one.
But I do think that it shows that it's something that needs to be defined, because there's no way that if frailty was a defined thing of X, Y, A, B, we would have 67. You said 64.
67.
67, so it's not a square.
No, 8 squared is 64.
Oh, okay.
So it's more than the square of 8.
Oh, okay.
Which is insane.
I thought my math was wrong.
No, your math is great.
It must be something that we need to define or not define. But I don't think that we treat something well when it's undefined.
Right. I think that the definition of increased vulnerability to adverse health outcomes is so vague. We should come up with something more specific, but I don't know how that would work because it's so varied from person to person.
Yeah, and from culture to culture.
Right.
Thank you for listening. As always, you can write to us what you want to hear about. Even in frailty itself, feel free to just reach out with either articles or subjects that you want to explore more. I'm Tali Spaceman.
I'm Erinn Carey.
And as always, stay funky.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you enjoy this content, I highly encourage you to go to seniorrehabproject.com, where you can find more helpful episodes, lots of free resources, and to see how you can become a game changer and influence the direction of this movement. I appreciate you, and I'll talk with you soon. But in the meantime, do not forget to stay funky.